Good afternoon. It's my pleasure to introduce Dr. Steve Chung. Dr. Chung is the Professor of Neurology and Director of Epilepsy at Banner University Medical Center, Arizona. Dr. Chung?
Thank you, Tracy.
Yeah.
Does anyone have a clicker? I think Mona left it with it. That's okay. We're going to get started and maybe somebody can find it for me somewhere. My name is Steve Chung, and we're going to talk about something different and interesting. And I'm not going to give you a talk. I'm going to answer your questions today the best I can. So just don't worry about sit through and then a lot of boring slides. Mine is actually very interesting, by the way. Let me just ask you, how many people are concerned about their mood? Your mood, your patient, the person who has epilepsy, their mood, and people around. Pretty much everybody, even though I saw only 5 hands. This is one of the most common things people do ask. The second part, cognition. Cognition we're talking about, when I say cognition, which term and idea comes to your mind most immediately? Memories and dementia and Alzheimer's. I don't know how many times people come to me, even during the ride to this, I just came in today from Phoenix. I was looking at my slide, and then of course the person next to me and leaned over and say, "Hey, you must be a neurologist." I say, "Yes, I am." I say, "Let me ask about my memory problem." What can I do for you? What can I do for that? So it is very common. And it is not just adult people or older people. We're talking about kids as well. Their ability to concentrate, ability to engage and perform in school, play, so on. So it is actually very common problems. You guys have been talking to neurologists. And neurologists are not psychiatrists. So when you ask about, I feel depressed, we just hear about the postpartum depression. Remember that the Mona did not talk about one thing about postpartum depression. That is, what to do with it. We see it, it's there, and you ask us, what should we do? And we're like, I'm a neurologist, go to a psychiatrist. Even though there's an overlap between psychiatry, they're dealing with the behavior, and some of dementia or the cognition, neurologists thinking that's their realm, and we don't really focusing on this type of problems. So even though, we thought that you left with it.
Stole this. Intentionally.
Well, the airport.
We know where you work. But it comes up very frequently, but neurologists tend to avoid it because we don't know what to do with it, their patients. Well, let me ask you, let's start with the one at a time. Mood, patient's mood. We're talking about depression, anxiety, maybe some autistic behavior as well too. All of those kind of things. Are those related to seizure, or is it a separate issue? What do you think? Related. And why would you say it's related?
Well, it's funny, with my son, they've been treated very separately.
Yeah.
But with now finding an epileptologist that understands that they are connected and giving him the right medication, we've seen a remarkable improvement in his mood and his attention. But teachers all through school have said he wasn't working to his potential and had very hard problems with memory and concentration.
Great.
So, yeah.
Well, you found a very good neurologist. Stick to him or her.
Yes.
Don't ever let him or her retire. A lot of people think it's a separate issue, but in terms of what we do, as you mentioned, they're not really a separate issue. It's somehow yes and no kind of answer. Yes, they're related, but it is not the same. I'm going to talk about mostly today, rather than how it's different in separation, I'm going to talk more about how they're related. You just heard one great example. By treating epilepsy better, their mood had improved. Can there be an opposite direction? dealing with their depression better, and somehow they're improving seizures. What do you think? Can we do that? We kind of treating epilepsy better, and somehow they improve the mood. We get it. That makes sense. You have less seizures. You don't have a lot of side effect from the medication, maybe the right medication. How about the other way around? Would you say, if we can deal with the depression, let's just pick one, depression, somehow that results in better seizure care? What do you think? Okay, I gotta go home, man. You guys are not fun. Everybody's you guys know the answer already. Yeah, and I'm gonna show some evidence today. That's the only slides I'm gonna show. One of the rare slides I'm gonna show is how they're related, not just because they are happening in the same person, but also how they're interacted, and also that what treating one can improve the other, and vice versa. Okay. How about move on to the, I'm gonna have a two-part. The first part, we're gonna talk about the mood first, and the second part, we're gonna talk about cognition second. But what do you think about the cognition? Are they related? Epilepsy and cognition, are they related?
Definitely seems like that.
It's definitely, because, yeah, who does not have cognitive problems? I do. I can't remember about half of people I just met on the way here, their names. They gave me the card, I looked at it, but I have no idea what their names are. I would used to be a little bit better, not a whole lot better, but used to be better. When I become an epilepsy specialist, I talk to my mom, say, Mom, I'm gonna be a seizure specialist. And this is a mom who doesn't know what neurologist meant to begin with. And she said, oh, that's your fate. My fate? And then I heard a story that I was never heard from her before. So when I was a baby, maybe 1.5, next door teenage girl came over during the school day. My mom thought that was kind of odd, and dealing with playing with me. She was holding me, obviously I don't remember, and then she dropped me on the ground and have a seizure right there. Back then, if you have a seizure, you don't talk about it. You hide it as best you can. To even neighbors, anyone, to your relatives even. You hide it. So my mom never knew it. And there's nobody actually next door, so my mom actually took her to the hospital, and that's the time that she actually got the first treatment for epilepsy. So their parents would not deal with it. This is something different, it's gonna go away, and they wouldn't do anything. So my mom said, even when you're 1.5 years old, you help patient with epilepsy and get their treatment. So that's your fate. It is a kind of interesting story, but looking back, I'm thinking I could be smarter if I was not dropped. Right? I could be better talk today even. So I gotta first talk about any other questions before move on to some other things. What do you want to know about mood and cognition? Yes.
So, with cognition, is there any truth or is there any correlation between cognition and seizures? The more you have seizures, the more it causes brain injury, and you lose cognition because of it.
Okay, that's actually like two-part questions. Number one, I was just going to repeat your question in case people over there didn't hear. Bottom line is if you have more seizures, it's more likely you're going to have a cognitive problem or dementia. Am I going to develop Alzheimer's disease? So I know I have seizures. I know I have a recurrent seizures, and I'm taking medications. And I just heard my uncle is diagnosed with Alzheimer's. This is the most common questions the patients ask. Does it mean they're going to develop Alzheimer's too? Everybody's fearful of Alzheimer's disease or the significant dementia, thanks to the Hollywood action. It is not that common. First of all, let me just tell you that epilepsy does not lead into Alzheimer's disease or automatically into the dementia. There are certain population who had cognitive impairment to begin with, and seizures are part of that syndrome, of course they're going to develop or progress to have a dementia and some other cognitive problems. But epilepsy alone, let's say the people who start having seizures in the adulthood, they're not higher risk developing dementia. However, you heard from some of you probably at the talking about the epilepsy surgeries or not. The target of epilepsy surgery many times is an area called hippocampus. Hippocampus is center for the short-term memory. So yes, there's a correlation between epileptic syndrome, epilepsy seizures, and short-term memory. And that doesn't necessarily mean that you're going to develop the dementia. So in broad sense, people with epilepsy tend to have more cognitive problems. Underlying cause, medication, and seizures. How many seizures is that be enough to cause a brain damage? Nobody knows. In animal studies, if you have prolonged seizures, that is actually more likely to cause brain damage than number of seizures. So it's more of a duration in a sense. That's the animal study. But in human being, obviously for good reason, we don't test those things. We're not going to have, okay, you're going to have 100 seizures and we're not going to treat you and see what happens to your brain. You can't do that, right? So we don't do that. So we don't know the answer. Good question, though. What other questions? So what can I tell you? Yes?
So I have a question about the reverse. So my daughter's all of her symptoms got worse once she was diagnosed and put on we got, we're medically refractory, so we got the litany of medications, but I kind of see the opposite of like, the medications they're still not controlling the epilepsy, but they've created this it seems like, or it's very coincidental, this cascade of more memory issues and, mood and, low mood, depression, all of those things seem to be a side effect of trying to control the seizures.
Right, okay. Can I ask you to close the door if you don't mind? Yeah, that's actually a good question. So there's two, I kind of get most of it, but I feel like one, doing better with epilepsy sometimes have a little more behavior, not the cognition, behavioral problems. On the other hand, if you're untreated, then obviously the cognition get worse. Sometimes, even if you give the right medication, seizures are better, their cognition is not improving. So what is really the relationship? And that's what we're going to explore a little bit today. And you set us up really nicely to talk about and move on. But before I get to the next slide, I understand I didn't move the slide yet. But anybody else? One more question I can go with. Yeah.
Could you talk a little maybe about, I don't know if you can or not, about like autistic characteristics and like something like my son has LGS, because yeah, it's just like as we evolve, if we move along further, he's more and more autistic.
Yeah.
It's hard to explain to others.
It's about autism and the seizures. Well, obviously there's some overlap. But let me suggest this. We labeling this autism, they're not born with a diagnosis. We just define that kind of behavior as autism. But if you think about what is autism is, you can't really have a more engagement, taking care for others, concern for others. And those are usually in your own world. They could be very smart, or they may not, but you're kind of defined or confined in your own world. That is autism. And if you think about how come, it is actually a couple of things, genetic, social things, underlying brain problem, all those kind of things. But to me, it's looking at more capacity of the brain. Your brain is so small compared to the rest of your body, and it's busy seizing. Sometimes when you don't seize, the brain itself generates abnormal discharges. You're not seizing, but your brain really is not normal. So you can imagine, even when they're not having seizures, the brain is not functioning normally. And they can only address things to their own world. So limitation of the brain function can be presented as autism. So I want to actually, besides before even labeling as autism or not, I think it's more about what capacity brain can do in the especially in the growing children when their not brain is developed normally or functionally. So that's my kind of broad answer to you, but we're gonna explore some of them as well together too. So let's get right into it. We started the conversation having, okay, epilepsy, we're gonna do our best and everything may fall in good terms. That we understand, that you're gonna hear that throughout the day and tomorrow. Whether it's a surgery, laser, VNS, if you do the surgery, it's epilepsy better, everything is fine, or get better. My question is, how about the other way around? Treating depression, what is the impact on the epilepsy? And so on. So first question for you. If I have a patient, A has seizure disorder and have anxiety or depression. Person B, same type of seizure, same family kind of situation, same cause, let's say, both of them had a little head trauma in the past, same cause, same age of onset, but this person does not have depression. So the first question I want to ask you, and I want to use medication C. Which one starts with C? Something called cenobamate, but let's say medication C. I'm just going ABC, by the way. Medication C. Who's gonna do better in terms of seizure control? Not tolerability, not seizure control. Person A, who has epilepsy and depression, or person B, just epilepsy, or same. Better, worse, or same? What do you think? B? Who's gonna do better? Person A is gonna do better. So you're treating with medications, because some medication actually control the mood, right? Improve the mood. You're saying if I used medication, appropriate medication for A, the person with depression, they're gonna do better. Any other person, any other ideas here? It's okay. You can be wrong. I'm not gonna give you a grade.
Well, what I was thinking is that.
You say already B, so we're gonna move on.
Okay.
Well, actually, I know that like our son takes medications that are anti-seizure, but for mood stabilizing. So it seems like maybe it would address both.
Yeah. So again, the same idea. Maybe the medication can address both. Therefore, the person who has a seizure plus epilepsy plus depression may have a better seizure outcome. Okay, so you're actually agreeing with her. You should feel better, even though it's probably not the right answer.
I don't know if this is the answer, but I know that anxiety and stress are triggers for seizures. So
okay.
it's kind of chicken and egg, right? Like they are very related. And I've read studies that there's a huge overlap between anxiety and depression and just epilepsy. So I don't know if you can really pull it apart, but boy, are they connected, right?
So what's your answer then? Who's gonna do
I was
better?
going to say B.
The person B is doing better. The one
Yes.
does not have a mood problems.
Right.
How many people say they're about the same? Yeah, room for people. Great, this is what I like. You can have always the right answer, otherwise I don't have to give a talk here today. So let me move on to the answer to that person, the question just I told you. So this actually, it doesn't matter exactly how to read it, but this one tells you exactly the same scenario. So the blue line is the person A. Person A who has depression, depressive mood score high, plus epilepsy. Red line is a person only have epilepsy but no mood. What it's showing it here is likelihood the person's gonna remain seizure free with the seizure medication. And as you can see here, the person B is more likely, higher chance remain to be seizure free compared to the person A who has mood problem. So you're absolutely right. So if you go out there, there's see the cyanide station, they have a chocolate. You feel free to grab one there. Let me just show you before one that I skipped here. Let me just show you how common it is. Just to look at the top line, major depression. Control meaning the people who do not have epilepsy. Epilepsy patients, you can see about twice as higher. If you look at the suicide ideation, second from the bottom, again, it's increased. So both depression and likelihood they're going to harm themselves increases twofold, sometimes threefold in the anxiety. It increases if you have a mood problem. And so far we talked about they're not going to do well with the seizure medication even. Their outcome, seizure control, is less than those people who do not have a depression or other mood disorder. Now the second question. Side effect is another very important thing we dealing with the seizure medications or treatment. Again, person A, depression plus epilepsy, versus person B, just epilepsy. Who's going to have a more side effect from a medication? Person A. Okay, why do you think that way?
Why do I think that way?
Yeah. Or you're just good at guessing?
No, I would just, it just seems like the more you have, the more you have.
Yeah, disease burden. More you have it, more you're going to have other problems too, including side effect. I like that answer. Does everyone agree that A is going to have a more side effects? That's true. And without even showing the slide, there's studies done to looking at ASM, anti-seizure medication tolerability, is worse those people who had mood disorder. Now the third question, how about, you guys been talking about how important it is to adhere to the medication. We can only prescribe a medication. You can tell people to take a medication, but it's not going to work until you take it, right? So which person A or person B, who's going to have a better adherence to the medication? Taking more medication more regularly. B? Everybody says, oh, so easy, this one is easy. Okay, B. All right, last question on the mood. So this one shows, yeah, it's basically showing yes that it is. So I'm going to show you this because you may not know what it means. How many people heard about you can have a surgery for epilepsy? Yeah, that's half of the talk today.
Yeah.
But having a depression or mood disorder affect the outcome of surgery? Now we're talking about taking it out, not just the medication. Do you think person A versus person B, or no difference in terms of who's gonna be more likely to be seizure free after surgery? What do you think? We're talking about surgery, not just medication here. Cutting it out or burning it out.
Is this treated or untreated?
Both treated or untreated, yeah. But at the time of surgery, you have a higher score in the depression scores. What do you think? Because if you treat, doesn't mean that depression goes away.
I'm going to say the same problem.
So who's better, person A with mood and epilepsy, or person B only with epilepsy in terms of surgery outcome?
Which one would be better?
Better.
The one only with the epilepsy.
Only with epilepsy. You see the trend here already, even without knowing. That's why I only have 4 questions. The 5th question, you will get it by then. It is true. It is interesting. It was actually, I was shocked. Because if you think about it, there's really no good reason why depression predicts worse outcome. If I have to think about more scientifically, depression, if you look at the brain, area called limbic, the emotional center, is oftentimes it's the epilepsy surgery target. Hippocampus, amygdala, that's the emotional center. And if you remove it, and you have some problems, you remove it, I feel like that should do better. Because now the problem areas are gone. Maybe they have a mood problems because of some abnormal brain discharges that function in that area. So if you kind of take it out, it should do it much better. And I've seen people like that too. But overall, this is done by the endocriner and showing that you're absolutely right. If you have a depression, that alone predicts worse outcome for the epilepsy surgery. So the question here is, all right, no matter what we do, people with the mood problems do worse. Medication doesn't work well. They don't tolerate the medication well. Even surgery doesn't work. So what should we do?
Treat the depression.
Treat the depression. Great idea. Except neurologists, we're terrible at it. I'm terrible at depression. So sometimes we send to psychiatrists, but one of the things I'm persuading neurologists is it's okay, don't be afraid of treating depression. You can do it. It's another prescription. You can do it. And some of the good medications out there now. However, I have to tell you, there are certain medications that you have to avoid. And these are the medications you definitely have to avoid. Because these antidepressant medications can make seizure worse. Yeah, there's some medication that gets seizure worse. If you look at any antidepressant medication, and if you read this kind of a long package insert, one of them, all the antidepressant medications said risk to increase seizures. So that's why initially neurologists like, I don't want to cause more seizures by prescribing it. If I send to a psychiatrist, at least we can blame them. Like, we don't want to deal with it. But it is okay to prescribe, what are the medications you know? For the depression medications.
Yeah.
Lamictal is sometimes used for the mood stabilizing effect. You're absolutely right.
My daughter's on Keppra, and that because it helps with Keppra rage.
Yeah.
But it's also a good anti-seizure. But I was on it too, but I wasn't epileptic. I had a mood disorder, so I know
Right.
those work well together. We're pretty stable now.
I don't like the combination, by the way, but I'm going to tell you in a second. Maybe not. But what are the antidepressant medications you know of? Lexapro,
It's not.
Zoloft,
It's
citalopram. So those are the ones you mentioned is okay. What I mean by okay is chance to have increased seizures or more seizures. It's usually about 1% or less compared to these medications go all the way to above 10%. One of the common medication here, one of the commonly prescribed medication by the psychiatrist, I see that all the time. Wellbutrin, bupropion. And you guys heard that Wellbutrin is no good? No? No good for seizure. It causes a 9.49%, close to about 10% times, patients are experiencing increased seizures. Sometimes people who do not have epilepsy at all, maybe they already have some low threshold of seizures. If you use Wellbutrin, they have first-time seizure with it too. It's possible. It's been documented. It's in the package insert. So these are the ones you avoid. The problem is, Wellbutrin is one of the few medication among the antidepressant medication that tend not to cause weight gain. Most people actually do lose weight. So when psychiatrists say, okay, I gotta give medication that can cause weight gain, weight loss, which one do you think you want to pick? Wellbutrin, therefore, utilized quite a bit. And again, this is a difficult conversation I have to have when they come in with recurrent seizures and they're taking Wellbutrin, especially if they like it. It's like, my mood is better with it. But better to avoid these kind of medications. Any other questions?
I was just curious.
Go ahead.
If you, like, so she has seizures, she has a brother, he does not. If her brother's doctor wanted to prescribe opioids, should we say, oh, maybe we stay away from that? It's not related, but he doesn't have seizures.
No, not necessarily. If you don't have a seizures, I think it's pretty okay. If you have a seizure that genetically engineered, like for example, juvenile myoclonic epilepsy, that tends to run in the family, then I would try to be a little bit more careful. But it's a kind of a nobody else in the family have seizures. My grandfather never had it. Nobody, but just my child. I think everybody else can still use it. Yes.
Would you just start an SSRI, just one of them?
Yeah, if they have a symptoms, yeah.
They symptoms.
Right. We talked about citalopram. Citalopram is the one that I personally use quite a bit, but we're not going to get into that. Why? But you know, everything else is fine. Okay, good. So just be aware. Some medication like lamotrigine and medication called Aptium, sometimes they cover carbamazepine and Depakote. Those are the ones that we know can stabilize the mood. But yet there are medications that can cause more depression. We're talking about seizure medication, but even antidepressant medication can sometimes cause more seizures. What are the ones you know that were heard amongst the seizure medication we should avoid because it causes depression or anxiety and those kind of things? You just mentioned one of them. Go ahead. Keppra is one of them. Levetiracetam tend to cause irritability and some anger outburst, and up to 30% of time, 25 to 30%. The funny thing is, people are taking, they never volunteer. I'm irritable, I'm angry easily. It's usually their spouse or their family members. Yeah, if you have like a husband that has a seizure taking Keppra, that's the first time the wife will use the term, the J word for him. If it's vice versa, the B word is assigned to the woman. Won't say that. Anyway, so it's actually recognized by people surround them more readily than themselves. What other medications you know?
For us, Fintepla, it destroyed our lives for 6 months. It was a horrible one.
Yeah,
Neurologist
Fintepla could be
did.
just like any other medication, but it is not really one of the common medications people use anyways, or causing that kind of problem. Felbamate is actually less. If there's anything, Felbamate people tend to have a little more alertness, and due to the mechanism of action, it actually not as much as other medications. So other medications that commonly associated is somebody mentioned about the clobazam, the earlier lectures. They have some aggression, especially in the adult, not pediatrics, adult population. Zonisamide or Zonegran tend to have some of the effect as well too. So there are some medications that we tend to avoid if you're dealing with people who already have problem. Vicompa is another one. So there are some medications you just have to discuss. And first, we have to avoid those medications that cause mood problems. Second, we should select the proper medication to treat their depression and anxiety. And that would be the main thing. Once you do that, and treating along with the seizure medication, they do better. If you have to surgery even better outcome. So let's keep that in mind. It's as important just selecting the right seizure medication, but also other medications as well too. Yes?
Is that, so I have a teenager with medical practice.
Oh, I'm sorry.
It's probably anxiety.
Yeah.
Is that, by adding an SSRI, is that something that would then be long-term? Or to get through the teeth, like?
Yeah, you have to see, nobody likes to take a medication for lifelong, but obviously if you have long history of it, they're more likely. But if it's really teenage issues, maybe it's just you, I don't know, but it can be short term. The point here is, use a medication, but you don't have to marriage to the medication. Some of the epilepsy medication you actually have to take lifelong. But antidepressant medication in my practice, sometimes you start it and feel better, stop it, and then sometime later, do it again. Yes?
So we have a son and he is taking a few medications to kind of balance everything longevity of medication. So similarly to, he's been through a lot of seizure medications, is it similar on the other side for psychiatric, like it'll work for a while and then we have to change, or is that typical?
I don't know if is that's typical, but I certainly seen. Not only that, even blood pressure medication. Did you hear that? It worked for a while, but then it doesn't. So now I have to add another medication to it. So I think there's some certain level for all human beings, for all medical illness, we build some kind of resistance to certain medications along the time. So.
And then my second question is,
Yeah.
at which point this, so he's on Lamictal, he's on a pretty good dosage of Lamictal, and it's controlled. And we've already started the process of like preparing for, because he's been on it for about 3 to 4 years. Will the psychiatric symptoms increase as we're changing seizure medications? Or is it?
Yeah, so the question is, what seizure outcome, we kind of know, like 30% refractory, new medication may work better, all those kind of things. But in terms of depression, well, depression actually has a little bit more genetic lineage than epilepsy. Okay, epilepsy can cause by a lot of other things in adult. But depression without any kind of a cause, unless it's a PTSD, it's a little bit more family run. So, you know, if you look at your son's father, and if it depends on, is that you, sir? Okay. Okay, let's stop here. Because the next question. But the idea here is, I think depression is better outcome overall on the long haul than epilepsy in terms of coming off the medication and being on board. Yes.
Does the type of seizures you have play a part in how you respond? Like for example, for the Keppra, in my support group, there's 3 of us that have been on it. It's worked wonders for me. The other 2 also, they had Keppra rage, but they also had focal seizures where I have generalized. So does that make a difference?
If you look at overall, we're just genetically, obviously individual is different. We, as you alluded, there's a patient with an epilepsy, generalized epilepsy, the seizures are coming from both sides at the same time, absence seizures and juvenile myoclonic epilepsy, generalized as the seizures, and the focal onset seizures. So if you look at overall in that 2 group, patients with the focal onset seizures tend to have a more mood problems. The reason for that is you have like a frontal lobe, temporal lobe, and different part of the brain. And which part of the brain cause epilepsy more likely? Temporal lobe. If you look at the focal onset seizures, 70 to 75% people are seizures are coming from the temporal lobe. So if you're a betting man, anybody gamble here? Okay, don't volunteer. So it's temporal lobe epilepsy, you're probably right in 70% of times, and then 50% frontal lobe, and then elsewhere. If seizures are coming from the temporal lobe, they are the ones who had a lot more mood problems, because where is the mood center? Temporal lobe. So it's a kind of coincide. And if you look at the imaging studies, PET studies and SPECT scan, area is shrinking, is actually mapped together with epilepsy and the depression, major depression, a similar area. So temporal lobe followed by the frontal lobe and then generalized epilepsy. So it does actually matter. Yes?
Okay, how do you treat depression with vitamins and also seizures with vitamins?
Treat with what? Vitamins?
Vyvanse.
Vyvanse, yeah. Yeah?
So I think in the reverse, it's like had anti-seizure meds for mood stabilizers.
Would she answer the question?
Yeah.
Would you like to come up here with me? Okay. All right. So we're gonna move on to now. Did you have a question? Sorry. We're gonna move on to now. There's something very interesting, which this is to kind of show you that my summary of talk is right here. Everybody got it, right? But let me just show you this. This is actually one of the important messages that I'd like to share with you. So how you read this is, okay, we established that people who had epilepsy tend to have more likely to develop depression or has depression. And we already talked about they're kind of involving the similar area. So which one comes first? Depression or epilepsy? Or at the same time? They're twins? I used to think depression is more like a response to seizures. Seizures are embarrassing, at least, and debilitating functionally. I mean, you can't even drive a car for a while if you have depression. Who would not be depressed? So I thought that depression is common because it's a reaction to it, reaction to diagnosis of seizures. This one shows opposite. They look at the line in the middle. That's when the patient was diagnosed with epilepsy. And the bar, these are when they have a depression diagnosis. This one here is important. So even before the diagnosis of epilepsy, the incidence of depression increases and stays the same. It doesn't have to actually go up. So this study, published in one of the most important neurology journal, showing that depression in a lot of people comes first, not as a reaction to epilepsy, comes first. It kind of gives an idea that maybe whatever is going on in the brain, sometimes it manifests as depression, sometimes it manifests as anxiety, or epilepsy, or both, or all of the above. So I think we have to give a understanding that depression, therefore, is not going to necessarily go away completely just to treating the epilepsy alone. You have to separately address it too, most of the times.
Could part of that be that depression is easier to diagnose?
Depression is easier to diagnose? Depends on what kind of depression it is.
Yeah, that's
If you say depression is a major depression and some other things, and yeah. To me, it's easier to diagnose epilepsy than depression. So depends who you talk to.
But if epilepsy comes like at 2 years old, are you saying that there's depression prior to?
Oh, this is actually adults population. Is in kids you can't really assess the depression that well unless it's very obvious. It's 2-year-old. How are you gonna make a diagnosis of depression, right? So the second part we're gonna talk about the remaining 18 minutes, maybe 17 minutes if I give a 1 minute break, is about the cognition. We talked about a little bit already, but let me ask you the question. With all that so far, what do you want to know now? Not that I have a depression, I mean the answers. I'll tell you what my challenge is. I hear every single of my patient, they say, Dr. Chung, let me tell you, my brain, my memory is not what it used to be. I can say that too. All of you guys say, I have to yet to see. The patient comes and says, Dr. Chung, my memory is better than last year. Nobody says that. It always get worse. And then, what can I do? What should I do with that? If we have a magic pill, of course I'm going to give that magic pill. There are medications approved for the treatment of depression, but what is the treatment there? To make them smarter? If you look at the infomercial, yeah, some pills make you smarter. Not true. The medication approved depression is not necessarily restoring their function, but slow down the progression. So if depression going downhill like this fast, medication may actually slow down at best. And that's how depression medication has been approved. We call it disease modifying, which is reverting back and then now they become smarter. My memory is better than last year, that kind of things. We don't have a pill. We don't have anything to do that. So I know you probably asked the same question. It doesn't have to be even a neurologist. You probably asked that question. Anybody in your family has an MD degree, you probably asked that, like, what should I do about my memory? What do you do? Well, there's a certain thing. So let me tell you how I counsel my patients. There are two things, maybe more than two things. Number one, how do we learn? How do we even remember things? what do you have to do to remember things? Sleep better? Yeah, that's one of them. So part of the memory evaluation is to see how well you sleep. That's important. What else? Reminders. Tell me a little bit more about it. How do you remind yourself to have a better memory?
Post-it notes, alarms on phones, repetition.
Yeah, repetition. So you know studying habits. When you study once versus reading it twice, it's different. Even watching a movie, it's like you watch the movie for the third time. I never figured out why people watching the same movie over again and over again. But they said they got something more out of it. It's like, how can? They said and show everything there already, but they do. And you miss something and you get it. So repetition is always a good thing. What else? People forget about a whole lot these days. Okay, similar. You're watching, hearing, listening, all those kind of things are good. It's one very passive way of learning things. You have to put it into more active learning. How can you do the active learning? You talk about it, you teach people. Second, if you're all alone and nobody asks you to give a talk, what do you have to do?
Imagine yourself.
Something like a scrapbook. You do things, you write it, like a diary. I'm not asking you, all of you guys write a diary, but writing it down. Even post-it note, even if you don't remember where you put the post-it, by the acting of writing things down is actually very important. So there's some Harvard study, if who's gonna be getting always A's, they look at their notebooks and textbooks. People who get the B plus, B average, they underline, different colors, yellow highlighted, green highlighted. But people who really do well, they write things down in their note or separately so. So writing is actually very active learning, and you can actually remember better with it. So that's something you can do too. How about seizure patients and medications? We're going to talk about that a little bit now. Have you ever heard that any medication that causing more cognitive problems as a side effect? Yes, I hear the big nod over there. Which medication? Lots of epilepsy medication. That's right answer. Anything specific? Topiramate, Topamax, good.
Next, but also, I think it's probably my lamictal that does it.
Huh?
I just had that problem, and now I'm on lorazepam, so I think that's not
Okay, yeah, there are certain medications. It actually started with topiramate, and without going into detail, this is a first published paper saying there's something wrong about topiramate here, and it's showing that topiramate has more side effect. We actually did a study, and me and some other people say, hey, at the time the popular medication was Lamatrige and topiramate. Let's compare between two. Which one performed better? And short answer to that is Lamatrige actually did better than topiramate. So anywhere you look at, topiramate has always been blamed for causing cognition. Any other medication you know that causing cognition? Yeah, clobazam, Onfi, some other benzodiazepine. Obviously, there's a written side effect of it. Anything else? Gabapentin. Let me then, this is all good. Let me ask you this important question, which I will show you in a second. Data. Do you know then, seizure medications saying, yeah, I know that a lot of seizure medications do, but I know some medication probably not causing the cognitive side effect as much. Have you heard that medication? Felbamate? Okay, except we don't use that very often nowadays. I had like one patient out of 1,500 patients, so yeah, it's all on the Felbamate, your son, yeah. Anyone else? Have you heard that this should be one of the conversation when choose a medication. We talk about the mood, but another thing I want to talk about is how about the cognition? What is the impact of this medication cognition on my child, my sister, my family members? And did anybody share? Yeah, according to the study, this medication may not. Nothing? All right, I like it. So let me then share. We looked at, some of them are published by me, but ignore that. But we looked at new medications, because the idea here is a lot of new medication came out said, hey, you know what, it may not be that unique in terms of mechanism, it could be, but look, we have a better tolerability, especially in some of these concerning areas. So lacosamide is a Vimpat, brand name is a Vimpat, and they look at cognition specifically. So what do you mean by cognition? They break it down. Memory problem, that's the biggie, right? Concentration problem, and some of the mental impairment, those kind of things. Bottom line, when they look at the different dosage of a lacosamide, Vimpat, to the placebo, they're about the same. So there are people saying, oh, okay, Vimpat is not zero, as you can see, it's never, but it's not very high. They're causing cognitive problems. So what does that mean? When I choose a medication and somebody's having cognitive problem already, or from the existing medication, these are the medications, there are a few more, these are the medications I like to choose. What is the next one? So Vimpat is one, and there's some other studies done, not just my study, other studies done showing Vimpat is pretty good in terms of that kind of side effect. Next one is, which one is it? Breveracetam. Breviac is another medication that shows, yeah, they're looking at the purple one is, or the red one is the breveracetam, and the gray one is the placebo effect. And it's not as good as the other one, lacosamide, but that's pretty decent, 3% versus 1.5% and so on. So pretty good. Two more. This is psychiatric symptoms, but I'm going to go into the cenobamate. Cenobamate is the newest medication. You probably heard it so many times today, and tomorrow as well. Cenobamate is Xcopri cenobamate. This has not been published yet. We just finished analysis. Dr. Krauss is from Johns Hopkins, and he and I actually put things together and looking at their chance of developing cognitive side effect. Again, pretty good. Pretty good. Again, it's not zero, I have to emphasize that, but pretty good. And then the another one is actually the Aptium. I didn't show that. So it's so important these days. When the drug is now developed, they actually test it. How are they going to do cognitively? So have you heard of fenfluramine? Fenfluramine, okay? It's a medication that approved for the Lennox-Gastaut syndrome and Dravet syndrome. They actually did a study. And interesting enough, this one, not only showing it doesn't have an impact, in kids, we're talking about the children here, their performance, overall cognitive performance, improved. You can blame all of it because their seizures are better, yeah, but nonetheless, their overall cognition has improved, not worse, it's actually improved. So it's called, this kind of things are called a brief analysis, or brief is acronym for this testing different type of ideas or the cognition. And I think we're gonna be seeing a lot more brief analysis on the new medication and the seizure medications, because it actually can make the difference in separation, looking at different areas too, not just the one area. Yes?
So, I understand how they'll do the testing independently or individually, but do they ever test who's the medications used together in tandem, or three of them used together?
Yeah.
But those.
So the answer is no, but right now the studies are done and as an add-on medication. So somebody's taking Keppra already and now adding Xcopri versus placebo. That's how they compare. So they're taking more than one medication. But to your question, how about if you combine Xcopri and lacosamide? Are they going to do better? We don't know. But I assume they're going to better than Xcopri plus topiramate, right? Okay. All right, so I think we're running up. It's actually done. So let me just go ahead and answer a few more questions, and then Jeff Chung will be next speaker. Go ahead.
So, do they not require cognitive effects testing on older drugs?
No, not at all. No, they are actually only testing whether medication reduces seizures or not. That's it.
Okay, so this is new.
This is a very new, yes. I saw the one more hand there, yeah.
I'm just curious about are you finding that a lot of youth who have been diagnosed with epilepsy are then later having intensive psychiatric challenges? Like, is this a very common thing? Because I know, like, 10 years ago, we didn't know this was going to be a thing. This wasn't a part of our care plan.
Yeah. I think 10 years ago, I'd been doing this about 25 years, 28 years now. So we knew it. The cognition problem and the mood problems are happening with these patients. We actually didn't know what to do with them. And also, we don't have a lot of choices back then. So if I give the medication, seizures are better, but develop the cognitive problem, what should I do? Keep taking it.
Right? You can't go off the
Right.
medication.
So that's another point. We have now many medications. Why don't we choose the medication? Depends on person's need. If it's a mood's problem, it's a cognition's problem, we have a choice now. That's the whole point of it. All right. One last question. I was waiting for you. I know you're gonna ask me a question.
So I have a type of epilepsy that is actually formed by what's it called? A cortical malformation PNH. I have a heterotopia in my left posterior ventricle. Do you find for the psychiatric, if it's in a different part of the brain, you can see either better or worse? Because I know you mostly focused on frontal lobe epilepsy, which is the most common type.
Temporal lobe is more common. Yes. Yeah. So the cortical dysplasia, just very, very briefly, imagine the brain is a tiny bit, a dot when they're a baby, and then it has to grow bigger and bigger. And the brain cells are mostly outside, and inside is wiring, right, connections. It's amazing how brain knows exactly where to end up. But you can imagine there's some brain cells that say, I'm not gonna go there. I'm gonna go someplace else. We call it dysplasia. So it's a dysplasia, cortical malformation. It's a malform in a way. And once you go there, the connections are messed up. They're causing short circuiting, causing seizures. So a lot of times we actually take it out. Those cells are actually more inside because they moved out. They don't move out to the place. They just stick around. So near the ventricle in your case. So surgery is actually a very good option for that if it's only involving the one area. We do that quite a bit. Before, you have to dig it out. Now, put the laser and then burning with the laser. It's a much simpler procedure. However, how about that? Is that specifically those kind of things involved with depression and things? The answer is probably not. It all depends on the location. As a matter of fact, I venture to say you behave very well and probably don't have a lot of cognitive issues as well too, except having seizures and medications. Because that's the area that usually not well connected to the other part of the cortex where this cognition is coming from. So, well, thank you for the lively interaction today and have a wonderful day.